Good morning. So now you've heard all the pathophysiology of AKI. I'll present four not uncommon scenarios that you're likely to see. I have no disclosures. So the first case, a 65-year-old man with known alcohol dependence found down, unconscious in his living room floor, brought into the emergency department where he's intubated for airway protection. Vital signs following intubation: he's afebrile, blood pressure is low, 86/54. He's tachycardic, heart rate of 116. O2 sats are good on an FiO2 of 0.4. Labs are most remarkable for kidney injury of unclear duration. He has a metabolic acidosis with a gap. He's extremely hyperkalemic. Calcium is low, 7.6. Phos is extremely high at 8.5, and uric acid is within normal. The urine is noted to be red. After spinning the urine, the sample remains red. The plasma is yellow. Plasma is shown here, obviously. So, what is the most likely cause of his acute kidney injury? Hemolysis, rhabdo, acute intermittent porphyria, and PNH, paroxysmal nocturnal hemoglobinuria. I don't know, is there a way you can answer these questions? Okay. So let's go back. A and D are both hemolysis. Intermittent porphyria, the red color, is made by porphyrin, the heme moiety. The right answer is rhabdomyolysis. The reason is, so the red color, if you go back to your sample here, the red color in urine is caused by heme, which is bound to iron, and gives a red brownish tint to the urine. If you spin this down and the urine clears, it can only be one thing, and that's hematuria. Hemoglobin is still giving the color, but the cells are being precipitated by spinning. The other three examples given, the red color is caused by heme itself outside of erythrocytes and outside of myoglobin, and will not spin down. The red in the plasma, in hemoglobinuria, it's going to remain red because in hemolysis, hemoglobin is it's a rather large protein, 67 kilos, and it binds to haptoglobin. So it's going to remain in the supernatant. It's going to remain in the plasma long enough to be visualized, to impart a red hue. By contrast, myoglobin, it's a much smaller molecule, only 17 kilos. It gets very rapidly cleared by kidney. So you're not going to see it in plasma. You're not going to see it in supernatant after blood is spun down. And intermittent porphyria, this is obviously an incredibly rare entity. This is made by, it's a defect in hemoglobin metabolism, so it's actually a precursor of heme that's giving you the red color, and it's unlikely to be present in plasma of a sufficient degree. So the right answer here, if the plasma clears and the urine remains red, this is most likely to be caused by myoglobin, which is rhabdomyolysis. So by definition, rhabdo is the dissolution, the breakdown of skeletal muscle, leading to the leakage of contents into circulation. And it's numerous. It's basically the constituents of sarcoplasmic proteins, myoglobin, creatinine kinase, aldolase, electrolytes are not listed here, LDH, ALT, and AST. One of the most significant side effects of rhabdomyolysis is AKI. AKI increases the morbidity and mortality when patients present with rhabdo. 50% here, that's really an upper limit. It's up to 50%, and it's reported with some variability. If you take all reported case series, it ranges between 13 and 50%. And it's going to depend, obviously, on the patient population of the case series. AKI is much more common if your population is made up of trauma patients. The reason is that AKI from rhabdo is far more common if you have a comorbidity. For instance, volume depletion. It's more common in trauma, and it's more common in some toxins. It's much more likely to be present. The causes of rhabdomyolysis are multiple. The most common, they fall into roughly 8 categories. Crush syndrome, limb compression. This, again, is most likely to result in AKI because it's trauma and likely to be coincident with volume depletion. Strenuous exercise and seizures, I read about military recruits. The fact is, I see it in younger people who take up spinning for reasons that are unclear to me. Strenuous exercise often results or can result in rhabdomyolysis. Errors of muscle metabolism, mitochondrial disorders, disorders of glycolysis can result in rhabdomyolysis. And this one is notable in that it's often recurrent. So I had a gentleman, I got a consult this year, a patient who presented with classic rhabdomyolysis and acute kidney injury. Creatinine was about 3.5 when I saw him. And he was a young man, 24, 25 years old. And when I went to see him, he described, I was asking him what he was doing. He was hiking Mount Monadnock, which is, I guess, about 70 miles north of here. And he noticed cramping pain in his legs on the way down and kind of pushed through it. Maybe within 12, 15 hours, he noticed very, very dark urine. What was remarkable to me is that he said, at the end of the conversation, he said, well, the dark urine, he said, to tell you the truth, I get that all the time. I said, well, what do you mean you get it all the time? And he said, well, since I've been about 13 or 14, every time I do strenuous exercise, he said, I often notice very dark urine, and then I drink and it goes away. And it was literally not dark yellow concentrated urine. It was literally tea-colored. And this gentleman went on to have a workup, and he did have McArdle syndrome. He did have mitochondropathy, resulting in a propensity toward muscle injury. So disorders of glycolysis, errors of metabolism, recurrent rhabdomyolysis, and potentially recurrent AKI. Multiple infections can cause this. Influenza is one of the major ones. Heat stroke, malignant hypothermia, malignant neuroleptic syndrome, electrolyte disorders, notably hypokalemia and hypophosphatemia. Very uncommon to have AKI. It's unlikely that they would be volume depleted. Multiple drugs can cause this, both licit drugs, statins that we prescribe, and illicit drugs. The big one is cocaine, and alcohol is included here as an exogenous toxin. This reference here, Melly, this was a study from 2005, Johns Hopkins, 470 people or so, and of those biopsy-proven cases of AKI related to rhabdo, drugs was the most common cause of 46%. So I would put crush syndrome, perhaps the most important, and drugs very closely behind. Both of those are high risk for AKI. So what is the pathogenesis? Well, I alluded to this. Myoglobin is a relatively small protein, 17.8 kilos, very freely filtered, immediately cleared from the serum. And it appears in the urine when it exceeds the absorption capacity. There's an error here. This should be usually when it's the urine, you can see it in the urine, when the urine level exceeds 100 milligrams per deciliter. It is not the serum level on this slide, and I apologize, it's a typo. And the data from this are very old data from 70s to 80s when they actually measured this. Urine is visibly dark when myoglobin is present at a level over 100 milligrams per deciliter. It appears in the urine for a very short period of time. Like the gentleman I described to you, it was gone and cleared within hours. Most of the time, by the time patients come into the hospital, the urine, it may be dark concentrated, but it's not going to be Coca-Cola colored with myoglobin. You can still measure it using a dipstick. You can measure myoglobin, you can measure heme, showing dipstick positive, but it's not visibly apparent until you have a level of 100 milligrams per deciliter. How does myoglobin cause injury? I suspect Dr. Bonventre did discuss this to some degree. There are mainly three mechanisms. It causes direct proximal tubular injury, distal tubular obstruction. It precipitates in tubules with TAM horsefall protein, particularly with acidic urine, which to some degree defines our treatment. And it causes vasoconstriction. How do you diagnose rhabdo? Well, the diagnosis, by definition, a high CK suggests muscle injury, muscle dissolution. Because the CK is coming from muscle, no question. How do you diagnose AKI due to rhabdo? Well, that's much harder. There's no good biomarker. CK goes up with muscle injury, but there's no good correlation as to when the CK is high enough to result in acute kidney injury. Okay. There's no safe level below which you can say this person is not at risk for AKI, or this AKI is not due to this rhabdomyolysis. So CK is roughly useful. We all use it, but it's not a perfect biomarker. Most data suggest it's rare to have AKI if your CK is below 15,000, and that's the number we all carry around with us. The fact is, it has been reported you can have AKI at lower CK levels, either because the patient had a higher CK prior to presentation, or it's in the setting of significant volume depletion. The urine is typically dip positive. Again, this is a useful biomarker. The urine dipstick is picking up heme from myoglobin. This is not a marker of kidney injury per se. It's just suggesting that myoglobin, heme from myoglobin, is present in the urine. And I toyed with the idea with the gentleman I told you about. How does he know perhaps when he should stop, when he should replete his muscles and stop exercising? One of the ideas we tossed around was using a dipstick, because if he waits till his urine gets dark, the myoglobin is at a much higher level. The heme positive will pick up myoglobin at a much lower level than 100 mg per deciliter, and is useful in that regard. If you take a look at this urine under a microscope, it should be free of RBCs. So heme positive on dip, no RBCs on microscopic analysis, and that's a pretty good idea that there's myoglobin in the urine, okay? It does not tell you whether or not there's actual parenchymal injury. All right, all it is detecting hemoglobin from myoglobin. The patient is clearly at risk for acute AKI, for ATN, but it does not tell you that there's proximal tubule injury. You often see a low FeNA, And it's possible that this suggests, again, the primacy of vasoconstriction and occlusion rather than tubular necrosis. However, I would also suggest that many of the patients, when you look at case series, many of the patients may have been volume depleted. And to define parenchymal injury, what you really want to do is take a look at the slide and see muddy brown casts. Look at their response to volume. If they are heme positive in the urine on dipstick, and it's a very clean sediment, and they get better quickly with saline, I might hazard that there's myoglobin in the urine, but there's no parenchymal injury. It doesn't matter. You're going to treat them. They'll either get better or not and go on to define. Very few cases, take home point. None of these, very few cases have been biopsied. So what is the treatment? Well, the treatment of rhabdo is largely the prevention of AKI, and the mainstay is aggressive volume repletion. And this has been shown for a number of years now, that if you can get volume into people early, you can often, not always, but often prevent the AK from the acute tubular necrosis. Once it happens, you're not going to reverse it with volume. But if you can catch them early, you can prevent them with very vigorous volume repletion. It's not clear what fluid you should use. It's either normal saline or bicarbonate. There is a theoretical benefit to bicarbonate. In animal studies, it minimizes the precipitation of myoglobin. It may inhibit free radical injury by inhibiting redox cycling. It may inhibit the vasoconstriction. It could worsen the hypocalcemia, which is not uncommon with trauma-related rhabdomyolysis. Normal saline, the only disadvantage, honestly, you don't have this theoretic benefit that's defined here. You can and will develop a hyperchloremic metabolic acidosis. I find I use mostly normal saline, and I stress that there are no good trials that have proven a benefit of bicarbonate. If a person is acidemic or acidotic, it is reasonable to use bicarbonate. How about diuretics? Well, I would stay away from them unless your patient is completely volume replete. There is some data to suggest that mannitol may be of benefit. It's working as an antioxidant. It tends to increase urine flow. It might relieve tubular obstruction. These, again, are not rigorously tested, and some people recommend only using them only using mannitol with persistent, striking, marked elevations in CK. A loop diuretic, there are absolutely no data to support it, and in the absence of volume overload, I personally wouldn't bother with Lasix. The data are too speculative to suggest its use. And we've tried Lasix before in other forms of ATN, and it didn't work. The harm is that you're going to do more harm than good, in my opinion, with loop diuretics. So the treatment guidelines, and this is actually adapted from a 2009 paper, but it's largely the same today. It's high volume normal saline, and the suggestion is if your urine pH is low enough, you might consider alternating normal saline with D5W with plus 100 millimoles of bicarbonate. Remember, you want the tonicity of normal saline. You want to maintain a very high urine output of 200 mils an hour. The frequent potassium checks, your hyperkalemia may be disproportionate to your drop in GFR. Potassium is released from muscle, and you can have strikingly high potassium in these cases. Frequent K checks and treat hyperkalemia management as one would typically in any case of AKI. Correct hypocalcemia only in the setting of symptoms, only in the setting of tetany, or if there is severe enough hyperkalemia and you're treating the cardiac manifestations of high potassium. And the reason is there's often a rebound, hypercalcemia, as in the latter part of rhabdo. There's another possibility. Many of these cases will have very high phosphorus, and that it would be disadvantageous to precipitate calcium phosphate. Once they develop ATN, treatment is per usual. Wait for dialysis, treat their volume status to make it optimal with loop diuretics as necessary. There is a risk score that was developed by my colleagues at the Brigham and published a few years ago. And this was a very nice study that looked at a cohort from Mass General and Brigham here and identified risk factors for AKI in the setting of rhabdomyolysis. And having identified the risk factors, they assigned a risk score to all of them. And the high-risk patients, I think this was on the prior, so increasing age is higher risk, female gender is higher risk, the initial creatinine, the initial CPK, here, it was high risk, only above 40,000. Calcium and phosphate, bicarbonate, all were risk factors. And the origin of the cause for rhabdo, namely, it was trauma or drug-related. It was excluding seizure, syncope, exercise. So the seizure, syncope, exercise, relatively low risk for AKI. They defined scores to them. If you ended up with a low score, you had a less than 3% of developing AKI. Low score defined as 5, a high score defined as 10. The risk of AKI went from 5% with a low score, 3% actually, up to a high of about 59%. This was validated. It was developed at Mass Gen, validated at the Brigham. So it's a potentially useful if you have somebody come into an emergency room who may not fit high risk, and has a CK of 12, 13,000, you might consider not admitting them. I have to say, this has not been embraced. I'm not sure I would be comfortable sending anybody home from the ER with a CK that's 12,000. So this is not widely used, as far as I know, yet. It would be useful and hopefully will be followed up. And it's a very nice, valid risk score. We just don't know how it's going to work in the community yet. So let's move on. Case 2, a 48-year-old, previously healthy man, presented with fatigue, anorexia, weight loss, no new prescription over-the-counter meds, blood pressure is high, O2 sats are reasonable. Labs show very high potassium, hyponatremia, extremely high BUN of 271, creatinine of 25, and marked metabolic acidosis. Ultrasound shows significant dilated calyces, large ureter, very distended bladder. Patient is admitted, gets started on hemodialysis, gets bilateral nephrostomies and a suprapubic catheter. Foley cath was impossible to place because of urethral strictures. Urine output is copious. He gets dialyzed once and his creatinine BUN plummet with the diuresis. And for 2 weeks, his urine output is 6 liters a day, suggesting a severe post-obstructive polyuria. And he required a PICC line in order to get repleted with saline and potassium and bicarbonate for 8 weeks. It's a remarkable case. So what are the metabolic complications during post-obstructive polyuria? They include impairment in urinary concentrating ability, diluting ability, sodium reabsorption, acidification, or all of the above. And the answer, which is basically on the previous slide, is absolutely all of the above. You see marked increase in volume in diuresis, both from some AVP resistance, but also from a decrease in sodium reabsorption. These patients are often acidemic, they often have a metabolic acidosis rather, not too severe, 17 or 18, responsive to bicarbonate, but it may last for months. And we can define, so obstruction, it's largely a surgical issue. But it's defined by acuity. It can be chronic or acute. Severity, it can be complete or partial. And by location, location tends to define the cause and whether it's bilateral or unilateral. So anything from the bladder up is considered upper ureteral, upper tract, and it can certainly start anywhere from the kidney, from the calyces, from the tubules, on through the ureters. So most common, stones, blood clots in the ureter, could be external compression from tumor or retroperitoneal fibrosis, typically giving you a unilateral in the setting of stone or blood clots, and often external compression, or bilateral in the setting of retroperitoneal fibrosis, not always. Or it could be an obstruction in the bladder, by definition, giving you bilateral obstruction, benign prostatic hypertrophy, blood clots, or malignancy, or in this gentleman's case, a urethral stricture. So what causes the decline in GFR? Well, typically, this is elevated intratubular pressure gets transmitted back to the kidney. Recall that the driving pressure for GFR is going to be the pressure gradient between your glomerulus and Bowman space. Typically, the pressure in Bowman space is extremely low, and the pressure is defined by the difference between blood flow between the afferent and efferent arterioles, right? That's how, the injury of NSAIDs or the ACE inhibitor effect is altering intraglomerular pressure. If you have an obstruction downstream, the pressure in Bowman space increases and tends to equalize the intraglomerular pressure, the pressure gradient, and that will decrease your single nephron GFR. This has been well studied in animal models. There is a vasoconstriction following an early vasodilatory phase, an increase in blood flow. The later phase, vasoconstriction and a marked decrease in renal perfusion, ultimately with a reduction in the ultrafiltration coefficient as individual nephrons drop out. They recover, patients recover from this. The degree of recovery depends on the duration and the severity. Somebody with a partial obstruction, they're likely to have had that obstruction for longer. The AK you may not see as remarkable AKI, but they're more likely to have CKD. Somebody with a complete obstruction develops severe AKI, but it's detected fairly quickly. And complete obstruction, you actually get a complete recovery even after a week. If it goes on for too long, it's unlikely to recover. And this would be in the setting unilateral, complete obstruction unilateral. After 12 weeks, you've probably lost that kidney. And as mentioned, there is tubular dysfunction during the recovery phase. And in the kidney itself, there is progressive fibrosis that ultimately results in the CKD picture. All right, case 3. 65-year-old gentleman admitted for AFib with a rapid ventricular response. Hospital course is complicated by catheter-associated urosepsis. He's treated with ampicillin and sulbactam. 7 days into the course of antibiotics, he develops a diffuse erythematous rash across his chest, arms, and legs. He has an increase in creatinine from 0.9 to 1.7 after a week, and a progressive rise over the next 5 days to a BUN of 96 and a creatinine of 6.8. Past medical history is remarkable for AFib. hypertension, type 2 diabetes, on oral hypoglycemics, and normal baseline kidney function. He's on aspirin, metoprolol, lisinopril, again, the ampicillin, sulbactam, glipizide, and has received dopamine during the ICU stay for relative hypotension with systolic pressures in the 90. No known allergies. Exam, he's febrile, he's hypotensive, he's tachycardic, normal respiratory rate with some hypoxemia on 2 liters. And he has a diffuse erythematous rash over his chest, arms, and back. His bilateral crackles on auscultation. Again, he's tachycardic, but no pericardial friction rub, and JVP is about 12. He's overloaded, 2+ edema. Labs show a white count of 19, 12% eosinophils, a BUN of 96, and a creatinine of 6.8. Well, this is the garden path here. You request the following biomarkers to formulate a differential diagnosis of acute kidney injury. Fractional excretion of sodium. The fractional excretion here is 1.6%. This slide got shifted, I believe. Urinalysis and sediment shows white cell casts. The renal ultrasound is negative for hydro, and the EOs are 10% positive at 10%. So the presumptive diagnosis, based on good data, is that this is allergic interstitial nephritis due to ampicillin. The treatment recommended is Medrol, a gram, times 1, and then prednisone, and he receives that. Creatinine continues to rise after 1 week of steroids, and he gets started on dialysis, and a kidney biopsy is performed. And here's the end of that garden path. Here's the kidney biopsy. And what you see debris in the tubules consistent with ATN. You see some loss of brush border of the proximal tubules consistent with ATN. What you don't see is an inflammatory cell infiltrate consistent with AIN. So the pathologic diagnosis is ATN. And there was no evidence of acute or chronic tubulointerstitial nephritis. Well, I looked hard for the teaching point of this. I truly do think we were led down the garden path. I guess the teaching point is common things are common in the ICU, and ATN still beats out AIN as your most likely diagnosis. None of our biomarkers are perfect, and certainly the fractional excretion of sodium was intermediate. It did not tell us a lot. It was between 1 and 2. The cell casts, well, they certainly do suggest AIN, but cell casts have been seen with ATN. We don't have a super good biomarker, I suppose, for AIN yet. And the sine qua non is that he really didn't respond to treatment, and you needed the gold standard, which was a kidney biopsy. So what can I tell you about AIN? And I'm a little bit reluctant. I believe you're getting a lecture from Dr. Paik on this very subject, so I will try not to make it too prolonged. AIN is not uncommon. It's well described and has been for years. It's a common cause of unexplained AKI in a series of 109 patients with AKI with biopsies. 27% had AIN. The vast majority of these cases are drug-related, 70%. This percentage varies somewhat based on the case series you're looking at. It tends to go up. In an older population, drug-related causes are even more likely. Younger population, autoimmune systemic disease increases in percentage. Even among young people, however, drug-related AIN is far more common. What are the agents? Well, the top 3, NSAIDs, penicillin, and proton pump inhibitors. I would move that up. But certainly, the list of drugs that cause AIN gets longer every day. And it's somewhat challenging to implicate particular drugs unless you have repeated reports of it, as is the case with penicillin, NSAIDs, and PPIs. It can occur with numerous infections. Legionella is certainly the one we all think of. Something that's missing here is TB. Granulomatous interstitial nephritis is not uncommon in tuberculosis. Were I to do this slide over again, I would probably move autoimmune disorders up because I believe that is more common than infection-related causes. And I would add to this lupus, Sjogren's, and Tinus syndrome, sarcoid. There's some variability again in case reports, but sarcoid is one of the major causes of autoimmune-related or systemic disorder-related AIN. It can occur in ANCA-associated vasculitis as well. The timing of onset, again, this refers to drug-related. 3 to 5 days after your second exposure to the drug. It can occur weeks with the first exposure to a drug. And I would say probably months after your first exposure. I suspect either Dr. Lamb or Dr. Paik will be discussing AIN related to checkpoint inhibitors, and that was clearly weeks to months after presentation of the drug. This classic triad, fever, rash, eosinophils, it's uncommon that you see it all three together. 10%, I would see possibly even lower than that. You certainly can see white cells in the urine and white cell casts, and in my opinion, that's the most useful part, both to exclude other causes of AKI. But a white cell cast, and again, the case I described to you was to some ways, it was rather an anomaly to have such a clear-cut white cell cast and have it not turn out to be AIN. You can see evidence of tubular disorders, of Fanconi syndrome, RTAs, glucosuria. The gallium scan, the data are all over the place. I don't think it's useful in practice for diagnosing. The sine qua non, the gold standard, is a kidney biopsy, infiltrate of monocytes, eosinophils. Treatment, well, again, presuming this is drug-related, critical, the mainstay is going to be going through the drug list and getting rid of any possible culprits. Certainly, a new drug recently added is still going to be highest at your list, and I would discontinue any and all that I could. The steroids, I have to say, most people give them. The data are contentious. They're all observational data. There's no randomized trial. Some studies, and there is more than one, suggest that starting steroids early can limit the course of AIN. And as I said, most studies are observational. These are the two large ones that we tend to cite. One was Gonzalez, published in 2008. The other one was Clarkson in 2004. Dr. Gonzalez and company found a delay in starting steroids. It was associated linearly with the final creatinine. If you delayed steroids, your final creatinine was likely to settle out at a higher level. Clarkson found no benefit between steroids and conservative management. I stress these are all observational studies. They went back over the data, biopsy-proven cases, and they took the cohort. These patients were treated with steroids, these patients were not. And it's markedly disproportionate because 3/4 of the patients are all being treated with steroids. I think it comes down to your risk benefit. If your patient is likely to tolerate steroids, you're likely to give them, and that appears to be customary. That's the state of the art. Case 4, I'll make this very quick. 47-year-old, previously healthy, no meds, develops recurrent uveitis prior to a rise in creatinine. It has recurrence. Both episodes are treated with topical steroids. Creatinine then bumps from 0.9 to 2.5, and she's sent to a nephrologist. We'll go through this super quick. Exam is unremarkable. She has, except for the mild conjunctivitis, she has a decline in GFR of unclear duration. Creatinine is 2.5. She has some protein, less than a gram, no white cells. ANCA is negative, GBM is negative, complement is negative, is normal, SPEP, UPEP negative, ANA, double-stranded DNA, ultrasound looks good. Most likely diagnosis is sarcoid, Behçet's, lupus, TNU, Sjogren's, and Wegener's. Okay, so the answer here is TNU syndrome. Described 1975. There are reports all over the literature now. It's basically an anterior bilateral uveitis with acute kidney injury, and this can occur. Most of the data are in the ophthalmology literature. Roughly, there's a span of about 14 months. You can get the uveitis first. 12 months later, you can get the AKI, vice versa. Most patients present with the AKI first, actually, and then develop the uveitis. Uveitis is typically bilateral. Patients present with blurred vision, more common in women. The treatment is steroids. Most typically, it's topical. These patients seem to respond to the topical. Certainly, the uveitis responds. Pathogenesis is unknown. There are some data that it may be HLA linked. This is the case of after the diagnosis of uveitis and of TNU syndrome was made. The patient was recommended prednisone, and her creatinine declined over time, presumably with the prednisone, but no, the patient actually refused systemic steroids and the creatinine still declined. It is not uncommon that the creatinine waxes and wanes in these patients. The take-home point with this, it is recurrent AKI, recurrent interstitial nephritis, and I suspect it's being reported with increasing frequency because we're now looking at it. And this, in my opinion, this brings home two take-home points. If you have a patient with AIN and you don't have a culprit drug, we should probably all be sending them to ophthalmologists, because I wouldn't recognize an anterior uveitis if it looked me in the face. We should probably be getting ophthalmology exams. I suspect it's being reported more because people are now looking for it. The other thing is that many of the cases that were originally reported as drug-induced AIN develop recurrent interstitial nephritis months, years down the road. This was a follow-up study published in NDT in 2018, and many of those cases turned out to be TNU syndrome. Take-home point of that one, you have a patient even with drug-related AIN, keep an eye on them. Their PCP should be following their kidney function, because it's possible we're overestimating drug-related causes and maybe underestimating this TNU syndrome or other immune disorders. So these are the four cases: rhabdo, obstructive uropathy, AIN that turned out to be acute tubular necrosis, and TNU syndrome. Thank you.